cold stress.txt notepad window focused on cold stress causes a complex set of physiological and psychological responses. Often before there is a drop in deep body temperature, i.e., rectal or other core body temperature. These responses are dependent on the nature and severity of the cold thermal stress applied. The drop in deep body temperature that follows prolonged cold stress is typically gradual and may exacerbate previous performance decrements or create new ones. When deep body temperature falls below the normal resting range of body temperature around 37 degrees C, it can be regarded as a beginning stage of hypothermia. But hypothermia is generally defined clinically as a deep body temperature below 35 degrees C or about 95 degrees F. Figure 12:1. The effects of deep body cooling on overt behavior are similar to the effects of general anesthesia. Levels of consciousness and alertness gradually decrease as body temperature drops toward 30 degrees C. 3. Responses become slow and reflexes sluggish. Speech becomes slurred and increasingly difficult. Mobility is impaired, and individuals often become drowsy or apathetic. As will be noted in detail later, there is evidence to suggest some impairment in memory registration, beginning at a core temperature of 36.7 degrees C and progressing to a point at about 34 degrees C to 35 degrees C. That which 70% of information normally retained is lost. 4. Concentration becomes increasingly impaired, although at early stages of hypothermia, 34 degrees C, 35 degrees C. The impairment appears to be in speed of mental operations rather than accuracy. Although lowered conducting military training or combat missions in cold environments poses a dual challenge, protecting the personnel from hypothermia and other forms of cold injury while also realizing the objectives of the mission. The goals of this chapter are to describe the components of the thermoregulatory system that influence peripheral and core temperature in cold environments, how the components respond to a cold environment, and what subsequently occurs when they are unable to maintain core temperature. In this chapter, we discussed the workings of the thermoregulatory system and emphasized the effects of hypothermia from the perspective of field medical practice. Central nervous system. Many different anecdotal and field studies indicate that the first signs of hypothermia are disruption of higher functions such as visual and auditory hallucinations. And as the core temperature drops further, slurring of speech, decreased consciousness, and impairment of short-term memory occurred. In one study, 28 local cooling of the inferior parietal lobe in a patient caused the patient to believe that his speech was being uttered by a stranger. It should be emphasized that these early signs might be the most critical for field operations. because they occur with mild hypothermia. In the field, monitoring an individual's behavior by whomever is in charge or a buddy is more effective than attempting to measure the core temperature. Changes in an individual's behavior, such as becoming withdrawn or silent, may indicate the early stages of hypothermia. Consciousness is usually lost at a body temperature of 28 degrees C to 30 degrees C, but there are isolated instances of persons still being able to talk when the core temperature was as low as 24 degrees C. 29. Although individual CNS neurons may be excited by a drop in temperature of 1 centigrade degree, not all neurons are uniformly activated because the brain does not cool uniformly. This is demonstrated by the significant non-uniformity in temperatures in various areas of the brain in dogs, sheep, monkeys, and cats. 30. In addition, the anatomical organization of the cortical neurons may partially explain CNS changes associated with hypothermia. Some neurons have lengthy axons that extend to the periphery of the brain, and therefore cold temperatures will interfere with their electrical activity. Thus, neurons in the cortex with vertical extensions from the nerve cell body may have cold-induced multiple spikes. 31. Eventually, hypothermia will cause a decrease in core temperature stage degrees C degrees F. Characteristics 37.699.6 plus minus 1 normal. Rectal temperature 37.098.6 plus minus 1 normal. Oral temperature 36.096.8. Increase in metabolic rate, blood pressure, and pre-shivering muscle tone. Mild 35.095.0. Urine temperature 34.8 degrees C. Maximum shivering thermogenesis 34.093.2 Amnesia. Desart 3.0 and poor judgment develop. Maladaptive behavior. Normal blood pressure, maximum respiratory stimulation, tachycardia, then progressive bradycardia 33.091 for ataxia and apathy develop. Linear depression of cerebral metabolism, tachypnea, then progressive decrease in respiratory minute volume. Cold diuresis moderate 32.089.6 stupor 25% decrease in oxygen consumption 31.087.8 extinguished shivering thermogenesis 30.086.0 atrial fibrillation and other arrhythmias develop. Poikilothermia. Pupils and cardiac output 67% abnormal. Insulin ineffective 29.085.2 progressive decrease in level of consciousness, pulse, and respiration. Pupils dilated. Paradoxical undressing 28.082.4 decreased ventricular fibrillation threshold 50% decrease in oxygen consumption and pulse. hypoventilation 27.0 80.6 loss of reflexes and voluntary motion severe 26.0 78.8 major acid-base disturbances no reflexes or response to pain 25.0 77.0 cerebral blood flow 33% of normal loss of cerebrovascular autoregulation cardiac output 45% of normal pulmonary edema may develop 24.0 75.2 significant hypertension and bradycardia 23.0 73.4 no corneal or oculocephalic reflexes areflexia 22.0 71.6 maximum risk of ventricular fibrillation 75% decrease in oxygen consumption 20.0 68.0 lowest resumption of cardiac electromechanical activity pulse 20% of normal 19.0 66.2 electroencephalographic silencing 18.0 64 or 8 systole 16.0 60.8 lowest adult survival from occidental hypothermia 115.2 59.2 lowest infant survival from occidental hypothermia 10.0 50.0 92% decrease in oxygen consumption 9.0 48.2 lowest survival from therapeutic hypothermia nerve conduction. For example, in human peripheral nerves, conduction velocity decreases from 30 meters/s at 35 degrees C to 12 meters/s at 21 degrees C. These decreases partially explain the observed motor incoordination and decrease in manual dexterity. Doc 32 There will also be some codeine duct muscle stiffness and decrease in blood flow to the limbs, which contribute to the incoordination and loss of strength at that core temperature. As core temperature continues to fall, cerebral metabolism decreases linearly from 6% to 10% for signs of hypothermia, genitourinary asterisk, polyuria, anuria, polyuria, testicular torsion, neurological depressed level of consciousness ataxia, dysarthria, amnesia, anesthesia, areflexia, poor subreflex, hypoesthesia, and nociception, initial hyperreflexia, hyporeflexia, central pontine, myelinolysis, dermatological asterisk, erythema, asterisk, pallor, asterisk, cyanosis, egress, scleroedema, ecchymosis, edema, permeabilis, frostnet, frostbite, paniculitis, cold urticaria, necrosis, gangrene, head, eye, ear, nose, throat, asterisk, rhinoreatheriasis, decreased corneal reflexes, extraocular muscle abnormalities, erythropsia, flushing, facial edema, epistaxis, strabismus, psychiatric asterisk, impaired judgment asterisk, perseveration asterisk, peculiar flat affect asterisk, altered mental status, paradoxical undressing, neuroses, psychoses, suicide, organic brain syndrome, anorexia, depression, apathy, irritability, cardiovascular asterisk, peripheral vasoconstriction asterisk, initial tachycardia, dysrhythmia, is decreased heart tones, hepatogen, alert reflux, jugular venous distension, hypertension, respiratory asterisk, initial tachypnea, adventitious sounds, bronchuria, progressive hypoventilation, apnea, musculoskeletal asterisk, increased muscle tone, asterisk, shivering, rigidity, or pseudo-rigor mortis, vertebral spasm, epistatos, compartment syndrome, gastrointestinal ileus, constipation, abdominal distension or rigidity, poor rectile tone, gastric dilation in neonates or in adults with myxedema, vomiting. Each 1 centigrade degree decrease in temperature from 35 degrees C to 25 degrees C. 31. Significant attenuation and frequency alterations in the brain's electrical activity can be observed at temperatures below 34 degrees C. 33-35. Most importantly, prolonged hypothermia of the brain affects cerebral functioning in a descending manner, so that cerebral cortex function is initially impaired, followed by subcortical structures. When medullary cellular activity is suppressed, cessation of respiration follows. This hypothermia-induced apnea can be reversed by warming the fourth ventricle. Complete absence of electrical activity. A flatland electroencephalogram normally occurs at temperatures below 20 degrees C. One of the challenges for medical officers involved in field operations in the cold is the fact that hypothermia will negatively affect an individual's performance, but paradoxically, once the person is hypothermic, the cold will transiently protect the brain from hypoxia. Fundamentally, it is still not clearly understood how hypothermia protects the brain from various hypoxic environments. Cooling the brain non-uniformly affects neural function, localized blood flow, and the integrity of the blood-brain barrier. Relative to other organ systems, a disproportionately high redistribution of blood flow is directed to the brain when profound hypothermia has occurred. Autoregulation of cerebral blood flow is maintained until brain temperature falls below 25 degrees C. Part of the explanation of the cold protective effect that hypothermia has on the brain is that it reduces vascular permeability and cerebrally non-ischemic rats. 36. Decreasing cerebral temperatures minimize hypoxia-induced abnormalities in the blood-brain barrier in ischemic animals. Rather, raising the temperature to 39 degrees C exacerbated the abnormalities. 37. In addition, mild hypothermia reduced the degree of post-ischemic edema in gerbils after 40 minutes of bilateral carotid occlusion. 38. Overall, these studies suggest that hypothermia reverses the destabilizing effects of hypoxia on cell membranes. Clinically, Profound hypothermia is induced to minimize or prevent cerebral ischemic injury during certain types of cardiac and cerebrovascular surgeries. 3941. The beneficial effects of clinically induced hypothermia classically have been attributed to a temperature-dependent reduction in metabolism. 35, 42, 43. As a result, whole body circulation can be arrested for prolonged periods exceeding 30 minutes without incurring severe cerebral injury. 39, 42, 44. The mechanism of neuroprotection associated with hypothermia is not clear. Profound hypothermia is not a strict prerequisite for neuronal protection, because significant cerebral protection may prioritize resuscitation requirements. 1. Maintenance of tissue oxygenation, adequate circulation, adequate ventilation. 2. Identification of primary versus secondary hypothermia. 3. Thermal stabilization, conduction, convection, radiation, evaporation, respiration. 4. Rewarming options: passive external rewarming, active external rewarming. Active rewarming occur at mildly cold temperatures, 33 degrees C, 34 degrees C. Improved post-ischemic neurological function has been reported in animals in which mild hypothermia was instituted. 45, 48. However, the neural-sparing effect of hypothermia may not be related to the timing of the ischemic insult. Improved outcomes following ischemia were apparent even when the hypothermia was induced either during or immediately after the occurrence of the ischemic event. 45, 46, 49. Further complicating this area are the observations that mild hypothermia induces cerebral protection, which has not been correlated to a reduced production of lactate, i.e., reduced anaerobic metabolism. 48, 49. Hence, a hypothermia-induced reduction in global cerebral metabolism per Southeast does not appear to be the complete explanation for the protective effects of mild hypothermia. Experimentally, the beneficial effects of mild hypothermia may be due to the following conditions: a reduced metabolism, temperature-induced alterations in ion channel function, which promotes calcium homeostasis, a major determinant of metabolism, increased membrane lipid stability, alterations in the release and reuptake of neurotransmitters, e.g., excitatory amino acids and dopamine, preservation of the blood-brain barrier, and the release of various substances that have a protective effect on cellular membrane function. However, these results have to be considered relative to the experimental animal used, as species vary in their ability to withstand cerebral hypoxia and hypothermia. This area of research is at present one of the most active, because hypothermia in some form may act to protect the hypoxic, physically traumatized brain. Motor activity. From a military point of view, The effects of a cold environment have their greatest overt effect on the motor system. Troops are not able to move as fast, and fine coordination is impaired. 50 cold hands make it difficult to pull a trigger or operate a keyboard. Cold stress and hypothermia influence motor function by way of the neural and cardiovascular systems and on the muscle cell itself. As a person is initially cold stressed and then becomes hypothermic, muscle tension leads to shivering, which continues until core temperature reaches 29 degrees C to 31 degrees C. Pre-shivering tone, of which cold stress subjects are usually unaware, normally precedes shivering. In part, this tonic muscle activity is the basis for the feeling of stiffness that most people experience when they get cold. 51 Increased motor tone has been reported to appear first in extensor and proximal muscles, which are the same muscles in which the amplitude of shiver is largest. 52 However, humans vary greatly in their shivering patterns, with some human subjects shivering first in their chest muscles. Shivering has been defined as involuntary rhythmic waxing and waning muscular contractions that are used to maintain the normal body temperature. 53 These oscillations are modulated by myotatic reflex loops, because deafferentation will cause the frequency characteristics of shiver to become irregular. 55 However, shivering can be influenced by cerebral cortex. The subject can temporarily turn off shivering by relaxing, doing exercises. 56 or modifying the breathing pattern. These techniques are invaluable for field operations, because they allow troops to conduct certain aspects of their mission even when they are cold stressed. 50 to 57 From a thermogenic point of view, shivering increases heat production to 5-fold more than is necessary for normal body heat production. During different phases of shivering, both agonist and antagonist muscles contract periodically but not necessarily reciprocally. Thus there will be an increase in muscle tension, but the limbs do not move effectively. The frequency of shiver varies from muscle to muscle but is considered fairly low, between 5 and 10 Hz. In laboratory experiments, cold stress subjects will demonstrate synchronized muscle contraction of all muscles monitored. If the antagonistic muscles were to be coactivated at higher rates or to elicit contraction, i.e., sustained force production without associated electrical activity, then the heat that could be generated would be proportionally greater. However, a major drawback to this type of activation would be the high degree of resultant limb stiffness that would limit one's ability to make superimposed voluntary movements. The control mechanisms for shiver have both central and peripheral nervous system components. CNS shivering was produced by localized coolant of the hypothalamus. 58-59 demonstrating the effect of peripheral temperatures on inducing shivering. Limer 60 reported that reducing subcutaneous temperature from 33 degrees C to 30 degrees C while maintaining the brain temperature of 38 degrees C evoked a shivering response, further supporting a role of peripheral regulation of the triggering of shivering are the observations that humans placed in a 10 degrees C environmental chamber for 15 to 40 minutes demonstrate intense shiver even though their core temperatures have not changed or are slightly increased. 61 in a field situation. Shivering is an important sign that all physiological systems are functioning, e.g., cold receptors, hypothalamus, muscles, and also that hypothermia may eventually occur. If shivering persons are able to complain about the environment, more than likely they are cold stressed or mildly hypothermic. Their ability to complain is an important sign that the troops may be in a critical situation, but they are not particularly hypothermic yet. Respiratory changes have been documented to alter increases and decreases in shiver amplitude or changes in duration for both. Inspiration of cold air causes an increase in rhythmic and tonic muscle activity, whereas inspiration of warm, humidified air can attenuate or stop spontaneous shivering. 62 When soldiers wish to minimize shivering, they should not inspire deeply. Although shivering generates heat and assists in minimizing a decrease in core temperature, it is not always desirable and may paradoxically influence a person's performance in many environmental situations, such as when a deep-sea diver is trying to perform a fine motor task. Shivering is clearly undesirable. Attempts have been made to minimize the occurrence of such tremors during diving by employing specialized high warm oxygen tanks to avoid hypothermia and prevent shiver. Although this technique minimizes shivering, it will not prevent the onset of hypothermia. Cold environmental temperatures affect the muscles directly, protecting them when frozen. There are clinical case reports discussed in greater detail. Chapter 14, Clinical Aspects of Freezing Cold Injury of Individuals with Frozen Limbs who have been successfully rewarmed with no apparent long-term effects. Respiratory system. The initial respiratory response to cold stress is a significant increase in rate hyperventilation, followed by a decrease hypoventilation. See Exhibit 11-2. Skin temperature afferents can influence respiratory function dramatically. Certain individuals will hyperventilate when they are exposed to a cold stress, and others will not. The cold-stressed hyperventilation is followed by a progressive decrease in the respiratory minute volume that is proportional to the decreasing metabolism. The control of respiration becomes compromised as the function of the brain stem is impaired by severe hypothermia. Respiratory rate falls from 15 to 7 breaths per minute at 30 degrees C to 7 to 4 breaths per minute at temperatures in the mid-20s. 76. Eventually, retention of carbon dioxide by the tissue leads to respiratory acidosis. In most cases of severe hypothermia, respiration diminishes and the heart continues to contract for some time in field situations. The evaluation of respiration in victims of hypothermia is extremely challenging, as their slow breathing rate might be masked by environmental conditions, e.g., wind, machine noise. Hypoxia can accelerate the decrease in core temperature in moderate cold stress situation. Hypercapnia lowered the threshold for shivering by 0.13 degrees C and increased the core cooling rate by approximately 25%. 78. This decrease in core temperature may be due to the hypercapnic hyperventilation. This observation is important because it demonstrates that in moderately cold environments, hypercapnia influences thermoregulation, whereas at very cold temperatures, the body's response is so vigorous that it swamps the hypercapnic effect. Stimulation of the respiratory drive by both carbon dioxide and hypoxia is absent at 20 degrees C. 79 during moderate hypothermia. In an absence of shiver, the reduction in oxygen consumption is associated with a parallel reduction in carbon dioxide production. Thus, what would be considered low levels of oxygen pressure in normothermic environments would be adequate at hypothermic levels. Although in hypothermia the arterial content of carbon dioxide is low, the solubility of carbon dioxide has increased as an individual becomes hypothermic. Several other physiological factors associated with respiratory function are influenced. 80. Ciliary motility decreases. Bronchuria is present. The potential for non-cardiogenic pulmonary edema increases as fluid shifts occur. The contractile function of the diaphragm and intercostal muscles alters. Lung compliance decreases. The elasticity of the thorax decreases, and anatomical and functional physiological respiratory dead spaces are increased, whereas individual alveolar dead spaces are unchanged. Pulmonary circulation time is usually prolonged unless there is interpulmonary shunting. Although hyperventilation is associated with cold stress, cold-induced respiratory rest also occurs. This reflex may be important in victims of submersion hypothermia. Such a response causes the person who is submerged to aspirate water and consequently drown. Simultaneously, the cold water aspirates rapidly, cools the brain and heart, because the heart continues to beat effectively while pumping cold blood. for 5 minutes after aspiration. The blood is rapidly cooled because it is circulated in the pulmonary cold water environment, dropping cerebral and cardiac temperatures. This rapid internal cooling is considered to be the explanation for the complete recovery of victims who experience cold water near drowning. When a person nearly drowns in cold water, there are approximately 45 minutes during which the victim may be successfully revived. The rapid internal cooling of the internal organs, such as the brain and heart, allows the victim to survive hypoxia for approximately 45 minutes. This form of cooling is more effective in children than adults because they have a smaller mass and a large surface area to volume ratio. Not all victims who suffered from submersion hypothermia were successfully revived. However, many remained comatose after heroic rescue and clinical attempts. This wide range of response may be due to a large number of variables, including the temperature of the water, the rate of cooling, the nature and quantity of the aspirate, and the clinical treatment. Fluid and electrolyte balance. Dehydration is usually associated with hypothermia, with free water depletion elevating serum sodium and osmolality. Because hypothermia produces natriuresis, saline depletion may be present. 69 Blood viscosity increases 2% per degree centigrade. Drop in temperature and hematocrits higher than 50% are seen. During rewarming, low circulatory plasma volume is often coupled with elevated total plasma volume. 99 Infusion of fluid does not always reverse hypothermia. Induced fluid shift. Normal saline had minimal lasting effects and did not hasten cardiovascular recovery from hypothermia. In another study, 110% low molecular weight dextran solution increased plasma volume and decreased blood sludging. In some patients with hypothermia, rapid volume expansion is critical. 101 NNAs. Adequate fluid resuscitation markedly decreases mortality. Immune system. The effect of hypothermia on the immune system is rarely considered in reviews. In a real-life scenario, hypothermia is usually associated with infections that might compromise the tolerance of the victim. In controlled cold stress or hypothermic studies in either Department of Defense laboratory or military field experiments in which the subjects were previously screened for illness, the hypothermic subjects rarely became sick. In an extensive number of hypothermic studies conducted at the University of Minnesota, in which more than 250 medical students were made mildly hypothermic, none became ill following a 3-week period of evaluation. However, in both hospitals and field operations, in which various stressors interact to compromise the immune system, hypothermia and infection go hand in hand. Everyday experiences demonstrate that decreased ambient temperature inhibits immune function. When a soldier injures a joint, for instance, ice is used to prevent the infiltration of immune cells and the subsequent release of inflammatory cytokines. Conversely, heat can be applied to abscesses to speed healing. The more dramatic example would be the high propensity of leukopenia and bacterial infections in children kept hypothermic for clinical reasons. 111. Although advances in immunology have not yet been integrated with existing knowledge of hypothermic sequelae, unanticipated non-thermal positive effects may be seen. 112. Fever augments immune function. 113. 114. Because hyperthermia to centigrade degrees above normal core temperature temporarily raises the mononuclear cell count in patients with cancer and increases the mitogenic response. 115. Thus, an increase in body temperature, whether induced or spontaneous, can confer an advantage to the immune response. On the other hand, decreases in core temperature are detrimental to immune function as opposed to having merely a neutral effect. 114. Sessler and colleagues 116 demonstrated that wounds are larger when beneath pigs that are infected under hypothermic conditions than in those infected under controlled conditions. Because more than half of the body volume is 1 inch from the surface and significantly cooler than the core body temperature of 37 degrees. See 117. Local skin temperatures may influence the growth of infections. Vasoconstriction lowers resistance to infection by decreasing the partial pressure of oxygen in tissues. 118. This decrease in oxygen pressure decreases oxygen and nitrogen-containing free radicals, both of which play major roles in microbial killing. One explanation for cold-induced immunosuppression is that the immune cells are specifically inhibited by decreased temperature. In cases of secondary hypothermia, when thermal compensatory mechanisms become inadequate, certain observations can be made about the effect of cold on specific populations of immune cells. Histamine release from type I mast cells is decreased at low temperatures. 119 and Bigger and colleagues 120 showed that neutrophils were impaired in their migration both in vivo and in vitro at reduced temperature. When the cooled cells were rewarmed, they exhibited optimal activity. In a clinical study, 121 hypothermic patients vasoassessed by tympanic temperature who had undergone colorectal surgery had more surgical wound infections and their sutures were removed 1 day later than patients who were given additional warming. Peripheral vasoconstriction was seen in 78% of the hypothermic patients versus 22% for the normothermic group. 121 from a military perspective. There was another interesting finding. 3 times as many infections were found among smokers in both groups. Minimizing smoking among troops might do as much to minimize infections postoperatively as efforts to rewarm patients who are mildly hypothermic. Huan Yang and colleagues 122 reported that some in vitro responses of helper T cells in mice are inhibited by cold, but that B cells were not similarly suppressed. Cold interfered with interleukin IL production in virgin helper T cells, implying an early block in the activation of these cells. However, the responses of these cells to IL-2 and IL-4 were not affected by cold. One of the most compelling, yet challenging, aspects of immunology is to understand the mechanisms by which individual parts integrate into a functional whole. Limited studies have addressed this important issue. Corticosteroids, which are released during cold stress, hypothermia, for both have a well-documented immunosuppressive effect. 123 When cold stress is applied to an animal, specific changes in the cellular components can be observed. Sanderson and colleagues 124 showed that when albino rats were subacutely stressed with cold water immersion, the total number of immune cells was initially expanded. Total white cell count was increased, as were total numbers of eosinophils and basophils. Phagocytic and avidity indices were also increased in phagocytic cells. However, Chek and colleagues 125 showed that prolonged cold water stress actually has an immunosuppressive effect. They reported a decreased number of thymocytes and splenocytes, as well as diminished blastogenesis of T cells and lowered activity of natural killer cells. Macrophages were found to be less responsive to interferon gamma, and because these antigen-presenting cells are crucial for initiating immune cascades, the impairment of macrophage function could be a significant cause of a dampened immune response. While the mice in the Chet experiment were obviously also stressed by anxiety and exercise, these results have implications for many settings of human accidental hypothermia. ARSTAT 126 reconfirmed the results of Chet in that an absolute value of cluster of differentiation for plus CD4 plus cells, which are most commonly considered to be helper T cells, was affected by cold stress, but not that of CD8 plus cells, which are most commonly considered to be killer T cells. In the ARSTAT experiments, the number of stressors per day, as well as the duration of the trial, were varied and had an effect on the various populations of cells. For example, Mice stretched once a day actually showed an increase in the percentage of CD4 plus cells, while the mice stretched twice a day showed a decrease. Current data suggest that the immune system is significantly impaired in hypothermic settings. Some studies, however, indicate the contrary, that antibody-antigen interactions may actually be stronger at colder temperatures. Further, the optimal working temperature of complement is said to be 20 degrees C to 25 degrees C. 127, however, as was previously reiterated, many of the cell-mediated responses and the microenvironmental conditions that are critical to an active immune response are made effective by cold. To emphasize what has been presented, two of the more important players for initiating an immune cascade, helper T lymphocytes and macrophages, are specifically inhibited by cold. Finally, it is also important to consider the microvasculature changes to cold, both local and throughout the body. Viscosity of the blood increases with cold, due in part to the aggregation of red blood cells and the increased adhesion of white blood cells to the endothelium. 128 capillary occlusion is possible, leading to hypoxic damage. Enrich and colleagues 128 report the result different from many others, namely, an observed increase in the permeability of the chilled vessels to macromolecules, leading to some leukocyte extravasation before the increased adherence of these cells. Overall, cold affects the immune response not only by inhibition of specific cells, but also through blood cell and vascular changes, such as alterations in viscosity of the blood and permeability of the vessels. Acclimation may play a major role in attenuating the response to an acute cold stress. Kizarki and colleagues 129 reported that in response to an acute cold stress, cold-acclimated mice exhibited a significant attenuation of the increases in serum corticosterone levels and the expression of the GC receptor messenger RNA on peritoneal exudate cells. If one can extrapolate from these studies to humans, it is conceivable that humans who are acclimated to cold may be able to withstand a cold stress and minimize any major alterations in their immune response. Text: cold stress causes a complex set of physiological and psychological responses, often before there is a drop in deep body temperature, i.e., rectal or other core body temperature. These responses are dependent on the nature and severity of the cold thermal stress applied. The drop in deep body temperature that follows prolonged cold stress is typically gradual and may exacerbate previous performance